Welcome to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions and we will discuss it on our pod. Hello, everybody. This is Josh and Adam. Welcome to another Dr. Journal Club podcast. Today we are joined with the incredible Dr. Monique Aucoin. Did I nail that?
Yeah.
Okay, awesome. From the University of Guelph. Did I nail that one?
Yeah.
Okay, nice. 2 for 2. Okay, I got all the hard ones out of the way. All right, so Dr. Aucoin, she and I, we kind of peripherally have known each other within the research realm for a while, but I don't think we officially met until the recent PI conference, and we just started chatting about, which, by the way, is like the preeminent and most amazing evidence-based medicine, integrative medicine conference there is. Would you agree, Dr. Aucoin?
I would, yeah.
There you go. I love that thing. Anyway, so we got to talking, I think, outside the building one day about evidence-based medicine and naturopathy, and it was just like, oh man, we got to continue this conversation on the pod. So that's what we're hoping to do today. So let me read a brief bio about Dr. Aucoin, and then we will jump in, hopefully, to a really fun, fascinating conversation, see what she's up to, and hopefully just have a good conversation about evidence-based practice in the naturopathic community in general. So Dr. Monique Aucoin is a licensed practicing naturopathic doctor and senior research fellow at the Canadian College of Naturopathic Medicine. So in my opinion, unofficial, and I'm not a graduate of CCNM, I think, hold your daggers, Bastille grads, that CCNM has been the standard bearer for EBM in the naturopathic community. Just saying it out loud. She is an adjunct professor at the University of Guelph, nailed it, in the Department of Human Health and Nutritional Sciences. Her clinical practice and research work focuses on the role of diet and nutrition in the treatment of mental illness. So cool. We had this really neat conversation about this on a car ride back to the hotel one day, I think. It was just really, really neat stuff that she's working on. And she is currently leading the world's first randomized controlled trial studying the effects of diet on the symptoms of generalized anxiety disorder. So cool. And this is what probably we'll talk more about today. Additionally, she is involved in research on the use of evidence within the naturopathic profession. I am obsessed with this topic and passionate about supporting NDs, naturopathic doctors, in improving their evidence-based practice skills. She co-founded CCNM's annual research day. That's amazing. And is an instructor and course developer at CCNM in the area of evidence-based practice. So just fabulous. I don't know, where should we start? I want to know where you got the bug, like how you got caught up with evidence-based practice as a naturopath, like what you think about it, what about the philosophy, how's it like playing out in real life, all the things. I just feel like you're our Canadian variant, and we need to learn a little bit more about you. So where did you get the bug for EBM and naturopathy?
Yeah, so I first started getting involved in research in that area a couple of years back. So I don't know if you know Dr. Matthew Leach from Australia.
Mm-hmm. Yeah.
He's a naturopathic doctor and a researcher. He has developed what's called the eBase questionnaire, which is a validated tool to measure skill, attitude, and use related to evidence-based practice. And he has conducted surveys of different professions within naturopathic medicine and other professions as well around the world. And he had reached out to myself and Dr. Cooley, who's the director of research at CCNM.
Yeah, Kieran. Still got to get him on the podcast.
Yeah, and asked us to collaborate on a project where we did a survey of Canadian MDs and using the e-based questionnaire, asked them about their skills and attitude and use related to evidence-based practice, as well as their training, barriers, and enablers. Um, and so we did that. We disseminated that survey, and we had about 250 NDs who responded.
Nice.
And the results were really encouraging. So we found that all of those sort of metrics were in the sort of moderate to high range. So skill and use and attitudes were all moderately high or
Are
high.
these self assessed skills or
They are, yes.
self
So it
assessed?
is
Okay.
self-rated,
Mm-hmm.
which we know has some limitations. So they were all in this sort of moderate to high range.
Mm-hmm.
But the participants also on the survey, they also recognized their limitations. So there was a question about, are you interested in learning or improving on your evidence-based practice skills? And I think it was about 90 to 95% said yes, they agreed with that statement. So
Nice.
we said, okay, we can see that there's some opportunity to improve the skills. And that's really, I will say that's really similar with other professions. When you
Yes.
look at any profession globally and survey them about their use of evidence-based practice across the board, we see there's opportunity for improvement. So that's not unique to our profession by any means. But there was also this maybe self-awareness that there was opportunity for improvement and an interest in improving those skills. So that survey was really the starting point. And then that was the jumping off point for a project that I did for my master's, where we did a evidence-based practice continuing education course.
For naturopaths, so it was for students or for already practicing clinicians?
Yeah, it was a continuing education course. So it was meant
Uh-huh.
for practicing NDs within Canada.
Nice.
And it was meant to really kind of build off of that survey. So we found, people's skills were pretty good, but they wanted to learn more. So we said, okay, let's sort of address that gap
Mm-hmm.
and try and sort of run with this project. So
Love it.
So we did it in two steps. The first step was a co-design process where we recruited NDs from across the country and conducted focus groups to try and understand what did evidence-based practice mean to them, what level of interest did they have in learning about evidence-based practice and this kind of course. Were they even willing to come and do this?
Mm-hmm.
And then what did they want to learn? What were their priorities? What were their interests? What kind of format? What did they want the course to look like? Because we really wanted that buy-in from those stakeholders. We wanted to make sure that we were creating something that was going to be useful and that people were going to benefit from and be willing to, spend time doing.
So I'm so curious because and I want to get like all the details on this in a sec, but I feel like, and Adam, tell me what you think about this, because in my experience teaching this stuff and doing surveys with the profession, like there's this sense that, and not just NDs, so with chiropractors and now with dietetics and nutrition students as well, there's a sense that we pretty much know this stuff. Like, yeah, we'd like to learn more, but then when you put them in an environment where you're like straight up like asking them about, what's the numbers needed to treat? How would you use this? How would you assess a diagnostic accuracy study? Like, how would you apply this? There's like that knowledge isn't there. And it's just that they just didn't know that they didn't know. And so I'm very curious about this gap. Adam, in your experience with NUNM and other providers in integrative clinic, do you feel like there's a similar thing there? Are you seeing a similar sort of thing?
Yeah, I would agree that the overall understanding of the importance of evidence-based medicine and the interest is there, but then when it comes kind of down to sort of like the fundamentals and the technicalities is where there seems to be a gap or sort of like a why kind of more not questioning the importance of it, but like having a hard time grasping the importance of knowing like the number needs to treat, hazard ratios, absolute risk reductions, when to do one over the other. And I don't think that's specific to our profession in general. I think that's kind of globally across medicine. But yeah, and one question I had too was in a lot of, I guess it would be sort of like these cross-sectional studies that are done on increasing uptake of evidence-based practice amongst educators is what I've seen in the literature is that there's always this sort of consistency of people wanting to engage in evidence-based medicine. They do a course in evidence-based medicine, but then there seems to be a drop-off sort of like at a follow-up period where the engagement isn't really there, if that makes sense. Like they're willing, they want to learn, they'll do a course, but the uptake still isn't that high. Have you seen that as well?
So this sort of touches on the next phase of the project. So just to steal my own thunder here. So the next step was that we did this course, and based on the findings of that focus group project, we developed a evidence-based practice continuing education course, and we evaluated it. So we did some pre-post evaluation, and we again repeated that e-base questionnaire, which has been validated and measured. As a result of participating in this course, were there any changes in attitude, skill, and use? And then we also repeated the use subsection of the questionnaire at 2 months post intervention.
So were they
because
applying
we wanted
it?
to because we wanted to sort of see what you're talking about, Adam, is like, did people actually implement what we
Nice.
talked about? We were curious. And then also, Josh, you had this comment about maybe people don't know what they don't know, and that's totally valid. I had the exact same thought when I was sort of starting this project. So when we did that pre-post evaluation of the course, we used the e-based questionnaire where they self-rated their skill, but then we also created a quiz. So we made a little quiz, like 20 questions about evidence-based practice, like some basic statistics and basics about searching for evidence and like some simple methodology questions, and we gave them that quiz at the beginning and end, because I also was concerned that maybe people would self-rate their knowledge as really high and then participate in the course and realize, oh my gosh, there's actually so much that I don't know, and then maybe rate their knowledge as lower after having taken the course, even though they'd actually learned stuff.
That's what we had at Pi, by the way. Like we haven't released the data yet, but like that's what we had at Pi. And what's it called when you there's a phenomenon like your confidence in the knowledge drops once you actually learn a little bit more for a while before you become an expert. And I think that's what we saw.
I don't know the term either. But
But okay, so and then before you tell us the results, which I really want to hear, like what I'm so curious, like what did they say they wanted to learn? Like when you did those focus groups, like what was it that they were after?
So they were interested in the course for the most part. And actually, I'll just give you one more little tidbit about the methodology. So we know that this is kind of slightly controversial in the profession, and that there's people with different views on this. So when we were screening people for the focus groups, we asked them one question and said, would you how much do you use evidence in your practice? And we got them to say like high, moderate, low, or very low. And then we grouped them. So we did separate focus groups for people who self-rated their evidence use as high, moderate, or low. And that was meant to sort of minimize tension, because we didn't want people to feel like they had different views or that their views weren't accepted within the focus group. So we had these 3 groups, and there were some themes that came up consistently across all 3 groups. And then there were some themes that were unique to those different subgroups based on sort of the attitudes of those groups of NDs. So across the board, people were interested in the course. Interestingly, the people in the high evidence use group wanted to incorporate more evidence, which I thought was really interesting. The people in the sort of moderate or low weren't necessarily interested in incorporating more evidence, but they were interested in improving their skills. So they wanted to become more efficient at searching, more effective at reading papers, and better able to understand, maybe more scientific, improve their scientific literacy. What else were the big takeaways?
How about the naive group? What were they after? The low use group. What were they after?
Yeah, so they were interested in improving their skills. So they recognized that they weren't necessarily interested in incorporating EBP more, but just to do it more skillfully. And we asked them things about, like, should there be a role of the principles of naturopathic medicine or philosophy? And again, that one varied. The high use group was kind of divided. The low use group said this is really important. So we definitely included that as a component within the course, like thinking about evidence within the context of naturopathic medicine and through the lens of naturopathic practice. And let's see what else. So they asked us, they really talked about lots of the core EBP skills. So they said, we want to get better at how to navigate databases and how to find relevant research. They wanted to get better at reading research and understanding different types of study methodology. They wanted to get a little bit of basic statistics, more comfortable, and how to apply research again within that naturopathic framework. So really, those steps of EBP is really what they told us, and it reflected this good understanding of EBP. When we talked about the definition, they had a good understanding. And recognize some of the strengths and limitations of evidence-based practice.
And so I've got kind of two things. One, that phenomenon, by the way, that you guys were talking about earlier is the Dunning-Kruger effect.
Thank you. Yes, that's right.
And then the other thing is, did you notice, or was there any sort of supporting data where people may have overinflated the amount of knowledge or skill sets they had in evidence-based medicine? Because we see it all the time when it comes to weight loss trials or weight loss studies, where almost across the board, people will always underreport and overreport how much. So they'll overreport how much they exercise, but actually underreport the number of calories they're consuming. And it's pretty consistent across the board that people are saying that they're eating less than when they actually are eating more. Are we seeing the same thing with your research, where people are saying, or are perhaps being overconfident with their knowledge base of evidence-based practice?
So it's hard to say because, like I said, primarily we were relying on a self-reported assessment tool. But we did say, Josh, is it okay if I tell you the results?
Please, yeah.
Okay.
Like, come on.
Well, we're not going to
let us have it already.
I'm going to tell you the results. Okay, so when we ask people about their skill, their use, and their knowledge before and after, we found that the skill and knowledge increased significantly from pre to post. So both their self-rated skill and the quiz, like their knowledge on the quiz, improved from before to after the course. So that was really encouraging. And their attitude and use of evidence did not change significantly. But the caveat is that they were both very high at baseline.
Oh, sure.
So this could have been a ceiling effect. So my sense is that when we said, hey, we're doing a course on evidence-based practice for Canadian NDs, the people who were really keen on evidence-based practice were the people who showed up. So we didn't really have much room to improve on their attitudes or use, because we got some excited people who were already pretty excited.
But their skills improved. So just academically, you trained them up well, and they learned it.
They did learn something. Yeah, that's encouraging.
I wonder about that. So clearly, right, there's a selection issue there. But also, if you were to make a course, especially continuing ed, it's not like you can force people to do it anyway. So it would be a selective group anyway. So it's a good cohort to test this out in. I am very interested in two things, and then I possibly yield the mic. I think I've been dominating. Sorry, Adam. I just like to find this stuff so interesting. So one is, how did you, because I'm obsessed with the integration of evidence and philosophy. So how did you, when they asked for that, how did you play that out in the course? So interested about that. And then also something that I had seen in my work is that there's a cohort effect where those that have graduated decades earlier seem less open to evidence-based practice, or less than, not on average, but less than cohorts that have graduated more recently. And I've seen that because I teach a fellowship program with MDs, NDs, DOs, like all of it. And I see that across the board, across professions. It's not just an ND thing. Anyway, did you see any sort of years out in practice effects at all? And then also, how did you integrate the philosophy piece in?
Yeah, so I would say the philosophy piece isn't my strongest area. So actually, Matthew Leach, who was keen on talking about that, he did a little segment teaching. So, but just sort of briefly, we talked about sort of thinking about the triad of evidence-based practice, and also thinking of philosophy. He kind of includes that as sort of a pseudo fourth pillar, as thinking about the evidence, the clinical expertise, patient values and preferences, and then also philosophy or principles of naturopathic medicine. And as you're interpreting evidence on a particular intervention, thinking about, does this fit with the philosophy of naturopathic medicine or the therapeutic order, and how does this either, jive or not? And that might influence whether or not we apply that evidence in that clinical situation.
Huh.
I've also seen another colleague who talked about sort of weighing the strength of the evidence, and then also weighing the sort of risks and benefits alongside. So when you're thinking about anything that has maybe less evidence, thinking about also what are the costs, what are the possible benefits, what are the risks, or what do we know about the safety profile, and how do we compare that to, say, other interventions that maybe have more evidence to support them, and sort of using those as some ways to think through weighing evidence on a topic that may or may not have as much evidence. And then, when you asked about time since graduation.
And you probably had a small sample size. I'm just curious if you suspect a signal at all.
Yeah, so we did some sub-analysis where we some like exploratory analysis where we look for correlations between some different demographic characteristics, like how long it had been since they graduated. To be honest, off the top of my head, I can't remember.
That's okay.
If you want, I can get back to you on that.
Okay.
It is in the publication.
Okay, cool. And we'll link to that publication. So
sure.
And so I've got two questions. One is, how are you, or at least what I'm seeing is that there's an interest when the evidence-based, or when the evidence source sort of supports our biases, and then sort of this disdain or this sort of wanting to step away from evidence-based practice when it starts to go against our biases. In how you sort of navigate that, or whenever there's any sort of pushback from other clinicians when you're trying to help, sort of increase the uptake of evidence-based practice. And then the second question is how, or what are you seeing being done with increasing uptake of evidence-based practice amongst students and residents?
So I would say there's quite a lot being done within CCNM, which is the institution that I'm familiar with, in terms of supporting evidence-based practice. There's a curriculum change that's currently in process within CCNM to more case-based learning, and it's really meant to encourage students from the beginning of their training to be thinking about cases in this evidence-based practice sort of model. So there's a lot of effort that's been done. So that was really some of the sort of driving force behind doing this continuing education course, is that here, the students that are being trained are getting this great education in this area, but the people who graduated weren't exposed to this training. And certainly in those focus groups, we heard that a lot. People said, when I was in my training, there was very little research methodology or research literacy component. So it's something that they didn't get a lot of training in if they had graduated quite a while back. Or we had people say, I loved the research course that I took at CCNM, but it was 10 years ago and I can't remember anything. So that for them, it was about either, learning those skills that they didn't get a chance to learn, or refreshing because it had been a long time.
Yeah. And I want to bring you back to, I think, Adam's question about pushing, like when we discount or when we overanalyze or over critique when it doesn't fit our biases. And I'm just thinking about that in context of the fourth stool analogy that you were saying. If one of the stools is a philosophy, which is almost a axiomatic belief structure, how does that work when the others are to evaluate the evidence in front of us? Like what wins out there? Like what are the pragmatics of that?
Yeah, and I would say that, that's not my model that I developed.
Right, fair enough.
You're more than welcome to bring Matthew on the show and
we'll
pick his brain on that. But my sense is that it's just another thing that we think about. So if we have this, intervention that we're interested in, it's got some evidence to support it, it seems to align with the patient values, thinking about, does this also fit with the naturopathic philosophy? Like, is this also supporting, helping the person to prevent further disease, or helping to encourage the body to heal itself? Or is this suppressive, or a treatment that isn't really supported, like doesn't really align with naturopathic approach.
Interesting. Yeah, we'll have to chat with him more about that. I'm curious how that plays out in actuality. And I think, and also to be fair, like I think about this a lot. I think that EBM is a philosophy axiomatic bias too, right? This idea that I feel like good medicine comes from evidence evaluation, like that's an axiom, right? And I feel like there are other people out there, definitely on the other side of the extreme, that are like, well, no, we get this knowledge from our elders, or we get this, there's other ways of knowing, like it's epistemological, I guess. So I'm not unaware of that counterpoint as well. Look, the thing is, we don't do this for money. This is pro bono. And quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence-based medicine and integrative medicine is essential. And there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession and integrative medicine and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause.
So I'm curious as to how you got into developing a clinical trial for anxiety.
Yeah. So this has been an area that I've been interested in for a long time, is how diet and food impact mood and anxiety disorders. I think that it's a really, really underappreciated area within at least the Canadian mental health system, which is what I'm familiar with here as a Canadian. The tragedy is that if you had a heart attack and you went to see a cardiologist, somebody's probably going to ask you some sort of question about what you eat. It might not be great, but the conversation is going to come up. Same thing if you had diabetes or irritable bowel syndrome. Hopefully somebody's going to ask a question about what you eat. But currently, we know in psychiatry that question's really coming up very infrequently, if at all. The idea that we should be concerned about what people are eating in terms of supporting their mental health is really underappreciated. So this is something that I've really wanted to shift the culture around. I collaborate a lot with a psychiatrist. Her name is Dr. Laura Lachance, who's also really passionate about thinking about food within the context of mental health. Just knowing that, the brain is an organ, like every other organ of our body, it needs proper fuel, and its functioning is going to depend on what's available for it to function. So we started off by doing some review work where we did two very large scoping reviews looking at what's been done on the topic of diet and mental health. The first paper was on psychosis. The second paper was on anxiety. And we really found that there's a lot of preclinical work, lots of animal evidence. There's tons of observational studies, although a lot of them are cross-sectional. There's some cohort studies where we see that better diet patterns might decrease the risk of developing mental illnesses, but there's very little experimental research that's been done. And the field, though, has really picked up in the last about 5 years. There was a study that I talk about all the time because I think it's really awesome. It's called the SMILE study that was done in Australia. And they recruited people with moderate to severe depression and gave them a modified Mediterranean diet for 12 weeks. And people had a significant improvement in their depression symptom scores. And I believe it was 1/3 of the participants no longer met criteria for depression at the end of the study. So it was really significant. And then that study has been sort of replicated. There's been other groups around the world that have done other studies where they provide a dietary intervention for people with depression, but nobody has done this kind of study involving participants with anxiety. So our study is the first to explore that area, and we've recruited all of our participants. Most people are finished; the last few are just participating. So we'll be doing some data analysis closer to the end of the year.
And are you able to share what like your primary outcomes are? Because what I've been disappointed in some of the mental health research as it pertains to like depression, anxiety is oftentimes primary outcomes are on like GAD-7 and PHQ-9 scores, as opposed to some sort of clinical outcome that's a little bit more meaningful. And so it sounds like there is some background research showing that, hey, no, we've actually been able to achieve remission, which is from a clinical standpoint fantastic. But if your PHQ score went from like a 14 to an 11, and now you're stating statistical significance, and I've also seen that clinically sometimes the scores that they're reporting don't necessarily align with actually how they're truly feeling. And perhaps there are some sort of like acute influences on that score, like, oh, I was just stressed out this morning, so this is actually more of a reflection as to how I'm feeling like in the moment versus how I felt since the last visit.
Mm-hmm. Yeah, mental health is a tricky one that way. We're relying a lot on these self-reported subjective outcome measures, and there's a lot of challenges in that field of study to measure the outcomes of treatment in a way that's going to be reliable and valid. But unfortunately, a lot of those questionnaires are considered gold standard for assessing changes. So for our study, the primary outcome was actually feasibility and acceptability because it's the first time it's been done. It was a pilot study, and then the secondary outcomes we did use the GAD-7, but we also looked at things like quality of life and self-efficacy. We looked at changes in diet quality, mindful eating habits, and as well as some biomarkers like some blood values.
What was the what was the diet? What was it based off of? Like, what did it look like?
So it's quite similar to the Mediterranean diet, although with some slight modifications just based on this previous work that we've done. So we did this scoping review. It looked at 1,500 articles on what we know about diet and anxiety, and we use that to
1,500? You reviewed 1,500
Yeah, it was a really
articles?
big review.
Like, you didn't screen 1,500, you reviewed 1,500?
Those were included, yeah.
Oh my dear God. Okay,
Yeah,
good for you.
It was a big project.
Wow.
We used Abstracker. I don't know if you've heard of it. It's like
but still.
yeah, it was a big project. Anyway, so it was mostly the Mediterranean diet, some slight modifications in our review. Caffeine came up as a really significant factor.
Wait, hold on. We may have to kick you off the podcast. Meaning that it's a good thing or a bad thing?
Not great for anxiety.
No. For anxiety. I guess that makes sense. Now, for depression, it might be a different story. Yeah.
And then things like adequate protein and blood sugar regulation were like lower glycemic index. And then also we focused a lot on behavior change and things like mindful eating. There was a lot of evidence when we look at what influences the dietary habits of people with anxiety. We saw that sort of eating for emotional regulation or comfort eating kind of behavior. So we developed some strategies to help people with those phenomenon as well.
Oh, fascinating. And then wait, all the questions. So then, like, it sounds like you had objective biomarker tests to make sure that they did make the change they reported that they made. And was that about the case? You saw that the diets did change?
So we, again, we don't have all the final data, so I can't tell you all the results. I can come back in a few minutes.
Yeah, we'll have an update, sure.
But that's the goal is, we're going to see their self-reported change in diet, but then also hoping to look at those blood markers to see if their reported change did something actually happen.
Very cool. And then is there a control group? Is it uncontrolled? It was
waitlist controlled.
Waitlist controlled. Gotcha. Okay. Very cool. Love it. Adam has a lot more experience in trials than I do. Adam, any other questions about the trial design or anything like that?
No questions about the design. I think that it's really exciting. I'm looking forward to reading it once it's actually available. And then what would you say would be the next steps for after this is published and you get some data going?
Yeah, so the goal would be then to scale it up. The pilot study was meant to kind of give us a sense of if this was feasible, and we asked them also some satisfaction questions about what they liked and what they didn't like, and how satisfied they were with the program. We're going to be doing some focus groups to get some more sort of rich qualitative data as well about their experience, and then the goal would be to use that information to refine it, improve on the design even further, and then scale it up to a larger sample size as well. It was sort of a narrow group that we were included. We had some, specific criteria, but certainly we could explore how this intervention impacted other populations as well.
So neat. And is it was it moderate, severe anxiety, mild anxiety?
Moderate to severe.
Moderate to severe. Okay, so you probably are going to get, I would imagine, a decent a signal there. And I don't know, Adam, I'd push back. Like if you had a drop that, well, we probably have an MID for, we have a minimal important difference for GAD7, don't we? What is it? I don't even know. I probably should know.
Off the top of my head, I don't know, but that's a great question. Yeah, for sure it exists.
How do you guys not know that?
I don't know how I don't know that either. Yeah. We might have to edit this podcast later and make us sound smarter than we are, but no, we'll model the fact that we don't know. But so for listeners, minimal important difference, super briefly, is sort of a minimum threshold we think of as clinically meaningful, so that if you have a really large study and you go from a 14 to an 11, like Adam said, and does that really matter? So we have these thresholds that are established for the more commonly used metrics or tools like GAD7 for anxiety. So I'm sure there's a threshold. So we would be looking to see, like, if after the diet, the average effect was larger than that minimal difference. I would feel, Adam, I feel like that would be, I'd be comfortable with that. I feel like that would be a good outcome. What would you measure objective? I mean, for depression, you can measure things like suicide attempts, but you need like massive effect. You need massive sample sizes for that, and you need severe depression. I don't even know what you would measure objectively for anxiety, maybe quality of life scales, which you're already doing.
Yeah. And sorry, I should have also mentioned within the intervention, we're doing the diet and then also an omega-3 supplement as well. So it's a combination. Yeah.
Oh, interesting. And that's probably what your biomarkers are on the omegas?
Yeah. We did the omega score, and part of our our eligibility criteria was that they had suboptimal omega-3 scores at baseline, although that was very easy to find when we were screening. There were very few people who had adequate omega-3 scores when we were doing that screening. But then also things like cholesterol and blood sugar markers, inflammation markers, a couple of vitamins.
Very cool.
Yeah.
And then I'm imagining you'll do like weight loss outcomes, secondary outcomes as well, or not even?
So within the field of nutritional psychiatry, the hypothesis is that improvements in mental health outcomes occur independently of weight loss. Mm-hmm. That by improving diet quality, that improves mental health, and weight loss improves mental health, but those are independent. So we told people to eat as much as they were hungry for. We have not given them any advice about losing weight. We did track weight before and after because we're curious, and we know that people are going to ask us, if they're feeling better, maybe it's because they have lost weight, but we're not expecting to see that.
Yeah, that'd be neat if it was independent. If it was like, weight stayed stable, but they feel fantastic. That would be
in some of the depression studies, it was the case. The weight didn't change, but improving diet quality improved the mental health outcomes.
Very Gotta neat. Get that Ozempic trial for depression then, or Ozempic for anxiety.
That is out of my scope. I don't know.
Monique is probably unfamiliar with our rather large obsession with Ozempic and that class of medications. But yeah, so that'll be interesting. We'll put it head to head for its impact on the GAD7. That'll be the next network meta-analysis, I'm afraid. But yeah, that is so cool. And so what was your, so I know it's just a feasibility study and like you're just getting it off the ground and you have to do that. But so how many people in that? And then are you going to try to leverage that, I imagine, for funding? Like, what does the outlook look like? I mean, this is a very important trial. And like, I think you said, it was like the only one that's been done like this. So have you seen a lot of interest from funders? What do you suspect in that regard? And how likely do you think you can launch the larger one?
Yeah, so our hope is that this pilot data will be useful in getting funding to show that we already can see that people were willing to do it. It was feasible and acceptable to the participants. And then we'll look at that outcome data as well. Another thing that we have in terms of our future goals, one of them is looking at cost. So whenever we're talking to psychiatrists, my colleague and I, we do a lot of knowledge translation, trying to get people talking and thinking about diet within the context of mental health. A big barrier that people often say is, well, it costs too much money to eat healthy food. And that's really actually, that might actually be a misunderstanding, or that might not actually be the case. So that SMILE study that they did in Australia, they asked people, they did a very detailed analysis of their diet before and during the intervention. And they did a cost analysis where they added up the cost of what they're eating. And they actually found that the cost during the intervention was lower, the cost of their groceries.
Really?
Yeah, and that's because people, a lot of these Mediterranean diets encourage things like beans and lentils, which are really, really inexpensive. If people are doing those sort of plant-based proteins instead of meat, they can save money. A lot of people, and then even in my study, I've had people just spontaneously report this. Somebody came in and said like, hey, I used to eat out lunch 5 days a week, and now I'm making all these lunches and I'm saving so much money. And I thought, wow, this is amazing data. Like, we need to capture this.
That's awesome.
Because that's a huge factor. Cost of groceries is on everybody's radar. And if we can help people to save money and eat better at the same time, then that's a win-win situation.
Yeah, that's very cool. And so are you requiring, or not requiring, but are you promoting the first thing I think about is like, okay, organic food's so expensive. Is that part of the diet that you prefer organic over non-organic, or it's more just veggies, Mediterranean in general?
Yeah, it's about diet quality. So the things are like increasing vegetables, increasing lentils, beans, chickpeas, including nuts and seeds, olive oil, limiting some of the like processed or highly sweetened foods, choosing water as your main beverage, choosing whole grains instead of simple carbs, including protein throughout the day, including fish. So some of those things may have some cost implications, but some of them, like choosing more beans and lentils, have some cost savings. So we haven't formally evaluated that in our pilot study, the impact of cost on groceries, but that's in our future plan as something that we'd like to do because we think it's so important from a acceptability and cost perspective.
Yeah, even if it's neutral, that would be huge, right? I think you're right about that assumption. People just assume it's way more expensive to eat in a healthy way. And then how are you measuring quality? So like, I know I'm not an expert in this, but I know that they have these like validated questionnaires for like diet scores, like Mediterranean diet scores. And I'm assuming they have quality scores. So like, what do you use and how are we defining quote unquote quality? Is it based off a Mediterranean diet or is it a separate thing?
Yep. So we did pick a Mediterranean diet quality score. It's called the Medilite. It's not too burdensome. It doesn't have a ton of questions, but it's meant to sort of capture how often people are having things like vegetables and fruit and legumes and complex carbs to sort of see how well their diet aligns with the Mediterranean diet in a numerical way. And that was part of our eligibility criteria as well. We couldn't enroll people who are already eating really well because they're already doing it. So we used this in our screening and then used it pre and post to see if there was a change.
And how many people did you have? I might have missed that. You might have already said.
Okay, 50.
50. Cool. Very, very cool. Awesome. Amazing. Adam, any other last minute questions before we wrap up?
No, that's it. And it's really, really exciting to see. And, hopefully we can get more funding for more development of this and kind of see this kind of play out from a feasibility study all the way up to large scale randomized control trial, even like multi-site and whatnot. So it'll be really exciting to see.
Yeah, that's awesome. I can't believe it hasn't been done yet. I mean, it just seems like such a smart move and so intuitive to do that. So good on you for making that happen. And thanks for your interest in drive and promotion of evidence-based practice within the naturopathic community. I just think that service is so huge and important. And, at some point we should talk. I'd love to see like what the actual course looked like, because it'd be neat to see if it can get implemented in other places as well. But yeah, very awesome. Great, amazing work you're doing. Any last minute things you want to share with the audience before we close?
Actually, I have one question. Sorry.
Go ahead.
What is the research day at CCNM? Like, can you just briefly give that sounds really interesting and like what does it entail?
Yep. So it's basically like a mini conference that happens at CCNM. We do poster presentations, and it's meant to profile research that's happening within our department, but also within other faculty members within CCNM and students who are involved in research. People make posters. We have a big event where we go and view each other's posters. We give out some really exciting prizes
Cool.
and accolades to the winners, and it's just meant to celebrate that culture of research within CCNM.
That's awesome.
Awesome.
Very cool. Well, anything you want to leave our audience with before we sign off?
Nope.
Okay. Well, thank you so much for coming on board and chatting with us about your amazing and very interesting work. And we'll have to bring you on another time.
Sounds great. Thanks so much for having me.
Okay. Take care. Bye-bye. If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media. At Dr. Journal Club, Dr. Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.